So now we are shifting gear from the molecular stuff we have heard this morning to more clinical and epidemiological studies. So I'll talk about glucagon in prediabetes. So we're celebrating 100 years of glucagon. So I took the opportunity to go back and see when were the first studies on glucagon in prediabetes. And I found this nice review from 1974, where they conclude that in prediabetes, glucagon levels have received only scant attention, but the available information suggests an enhanced response. And it appears that a better definition of the prediabetic state is required, in addition to techniques that can adequately quantify both secretion and clearance rates of these hormones. And so this is almost 50 years ago. So where are we today with a better definition of the prediabetic states? Well, we have better definitions. We have made a lot of studies trying to understand some of the subtypes of prediabetes. So today, prediabetes can be defined by fasting plasma glucose and 2-hour glucose. So it's a gray zone between having normal glucose tolerance and diabetes. And there are different forms of prediabetes. If people have elevated fasting glucose only, it's called isolated impaired fasting glycemia. And if people have elevated 2-hour glucose levels after an oral glucose tolerance test, they have isolated impaired glucose tolerance. And then they can have a combination of both, which is IFG and IgT. But we also have hemoglobin A1C, which is now also used to diagnose diabetes. And of course, then we can also find people with elevated risk of prediabetes by using HbA1c. But still, even though we have these better definitions, there's not consensus across the different organizations worldwide. There are different cut points, which are suggested by the ADA and the ESD and IDF. So there's not really consensus about what is prediabetes, how do we define it, and what characterizes people with prediabetes. But we looked into some of these subtypes of prediabetes many years ago. This was studies I did during my PhD, together with Jens Juul Holst, where we wanted to characterize people with different prediabetic subtypes. So what we found here was that people who have elevated 2-hour glucose, so that is impaired glucose tolerance, they have peripheral insulin resistance. This is measured by a clamp. Whereas people with impaired fasting glucose actually have a normal insulin sensitivity in the peripheral tissue. In contrast, the first phase insulin response seems to be impaired in people with impaired fasting glycemia, but it is normal in people with impaired glucose tolerance. And then we can calculate something called the disposition index, which is a measure of the relative beta cell dysfunction. So it's more or less you multiply the two measures, the insulin secretion and the insulin sensitivity. So of course there is some kind of impairment in beta cell function in both subtypes, because that's why they have hyperglycemia. So what about glucagon in prediabetes? We have had the opportunity to look into a large cohort called the Addition Pro study, consisting of almost 1,500 individuals, where we had very nice data from oral glucose tolerance tests. And here we were able to subdivide people into having normal glucose tolerance, prediabetes, or type 2 diabetes. And as you see here, which has also been mentioned earlier, in the fasting state, people with type 2 diabetes have hyperglucagonemia, but we also see that people with prediabetes have elevated fasting glucagon levels. And then we actually divided the glucagon suppression during the OGTT into an early phase consisting of the first 30 minutes and a late phase consisting of 30 minutes to 2 hours. And here we see quite different patterns. So we see that the early glucagon suppression is impaired in people with type 2 diabetes and actually also in people with prediabetes, but that the late phase glucagon suppression seems to be exaggerated in people with type 2 diabetes. You can see here also the subtypes of prediabetes. We looked at the glucagon levels, and quite surprisingly, there was no difference in fasting glucagon between people with impaired fasting glycemia and impaired glucose tolerance. But at 2 hours, we found decreased glucagon levels in people with impaired glucose tolerance. So people with elevated 2-hour glucose levels have lower glucagon levels, and they also have this exaggerated glucagon suppression, which may not be that surprising. We also studied the relationship between insulin sensitivity and glucagon in this population from the Addition Pro study. So here we subdivided the population. We stratified them by the degree of insulin sensitivity, to have a high degree of insulin sensitivity, a medium or low. So that means the red curves is people who are insulin resistant. And here we literally saw the same patterns as we identified in people with type 2 diabetes. So those who were most insulin resistant had the same glucagon response as those with type 2 diabetes. And for the medium degree of insulin sensitivity, we found the same as in people with prediabetes. These pattern of glucagon suppression and glucagon levels were, or this increased late glucagon suppression we found was associated with the changes in GIP, which increased during the late phase, and also the GLP-1 levels in a linear mixed model. And we have also shown in another study together with Nikolai, also on this population, that there is an association of the glucagon levels with amino acids, and also that hepatic insulin resistance seems to modify the relationship between glucagon and these amino acids. So the next question, now we know that there is an impairment of or elevated fasting glucagon levels in people with prediabetes. So can they be normalized, for instance, after weight loss or after a glucose-lowering intervention? So there's very diverse results from the different studies which have been performed over the years. So I'll just show you some examples. This is a study, a weight loss intervention in 24 men and women with obesity who were randomized to 6 months of intensive exercise and diet intervention or control. And here, during an oral glucose tolerance test, in the control group, there was no difference in glucagon before and after the intervention, but in the intervention group, they found a decrease in the fasting glucagon levels and also during the OGTT. So mainly the glucagon level seems to decrease. And this change in glucagon was associated with the body weight loss statistically. Then another study was performed in 70 healthy women with obesity. They were randomized to a paleo diet consisting of fruit and vegetables and fish and lean meat or control. And this study was for 2 years. And they observed a significant weight loss, but here they observed increased fasting glucagon levels after the weight loss. And they saw that there was no association between weight loss and glucagon levels. And then we have another study here showing it was in 20 individuals with obesity, all participating in a low-caloric diet intervention and followed by a weight maintenance period. And here there was no difference in the glucagon levels before and after the initial weight loss for 8 weeks and after 1 year. So very different results, which may, of course, be based on different populations and maybe also show how difficult it is to measure glucagon in the different populations. We then did a study a couple of years ago in people with prediabetes defined by having slightly elevated HbA1c levels. And they were randomized to 3 different glucose-lowering interventions. So this was dapagliflozin, which is an SGLT2 inhibitor, metformin, and exercise, and then we had a control group. And all participants had prediabetes based on HbA1c, and they were also overweight or obese. So what we found was small reductions in glycemia, in HbA1c, fasting glucose, and insulin. And also during the OGTT, we observed reductions in insulin. We actually observed an increase in glucose with the metformin treatment, which was quite surprising. But for glucagon, no differences significantly in all the intervention groups. So, take-home message. Prediabetes is not just one entity or one disease category, but there are several subtypes of prediabetes which all have different underlying pathophysiology and also very different glucagon profiles. We know from this large study that insulin resistance and prediabetes and also type 2 diabetes is associated with elevated fasting glucagon levels, also a poor glucagon suppression, at least in the early phase after an OGTT, but normal or even exaggerated glucagon suppression in the late phase towards the 2-hour value, and especially in people who have elevated 2-hour glucose, either as prediabetes or type 2 diabetes. We have also seen in these studies that weight loss or improvement of glycemia in people with overweight or obesity or prediabetes doesn't really seem to normalize these elevated glucagon levels, but there are very large differences between the studies, so it's quite difficult to conclude on this and also conclude on the importance of glucagon in this aspect. So with these words, I would like to thank all collaborators and sponsors of our studies. And thank you for listening.
Okay, so I think we've got thank you, Kirsten. That was very nicely summarized. There's a question over there.
Thank you, Kristine. So one thing I want to ask about is the two different subtypes you had, and in relation to like branch-change amino acids that are related to insulin resistance. And how do you could you couple that to the effect on glucagon, or you said the two different subtypes had different effect on glucagon, and then the branch-change amino acids, are they different in those two groups?
To be honest, I don't think we have studied whether the level of the branch-change amino acid differ between the groups. But we found that the branch-change amino acids was positively associated with glucagon, and the non-branch-change amino acids were inversely associated with glucagon. So it was different effects of the amino acids on glucagon levels. But I don't think we have looked into the subtypes of prediabetes in that respect. Maybe Nikolai can add if you know.
Okay, that's another question here.
Hi, thank you for a very interesting presentation. And I have a comment regarding the paleo diet. Could it be that, because paleo diet, we know that it excludes all the grain products, that's why protein contents, and especially arginine-rich food, are increased. And since we know that arginine and protein increases the glucagon production, could it be the result of 2 years study after following, despite the way the level was increased? And I can add it more, because I personally use these arginine-rich food as a preventing hypoglycemia in type 1 insulin-treated diabetes, because actually protein-rich food, especially after exercise before going to bed, prevents. And could it be because of the increase of glucagon level? Thank you.
I think it's a really, really good comment, and I think you are right that this is a plausible explanation for these findings. Thank you.
So, Kirsten, I've got one quick question for you. Where you've shown the conflicting data and changes in glucagon level at these interventions for prediabetes, is this correlated with weight loss? Because, in the clinical setting, we all, I don't know, it's currently our general thinking is that the greater than 10% weight loss will lead to, possibly remission or improvement in diabetes. So have you looked at that correlation?
But the studies actually tried to look at that, and some of them concluded that it was correlated with weight loss, and others concluded despite a weight loss, there was, for instance, an increase. So there's not consistency in the data regarding the association between the weight loss and the changes in glucagon. Okay. So I think the point is that there are many other factors like levels of GIP, GLP-1, insulin, glucose, the amino acids, and so on, which we also need to consider. It's too complex just to look at glucagon itself.
Yeah, and I think we discussed this briefly yesterday. How about C-peptide response, looking at beta cell reserve?
I'm not sure the studies have published on that, all of them. So I haven't looked into that.
Okay.
Good point.
Okay. No more questions? Okay, thank you very much, Kristine.